Hello, everybody. This Friday afternoon on the East Coast here of the U.S. Thank you for joining today's PCPCC webinar called Innovations in Caring for Persons with Alzheimer's and Related Dementias. During this webinar, attendees will hear from 3 organizations in their efforts to provide comprehensive, coordinated, patient-centered care for patients with Alzheimer's disease and other dementias. This is Rob Driven with Merck, and along with Julie Shills, who works for Mathematica. Together we are the executive committee liaisons between the PCPCC Board of Directors and the executive membership. So we're very privileged to be in that role. And today I'll be leading the discussion today with 3 experts who you'll hear from in just a little bit. For those of you who are not members of the PCPCC, I'd like to just take a brief opportunity to encourage you to consider doing so. Feel free to reach out to Jennifer Renton, who's the membership coordinator, if you're interested in joining the team-based primary care movement at PCPCC. As background for you, PCPCC brings together more than 60 organizations on the executive committee committed to empowered team-based primary care as the foundation of a high-value delivery system. I mentioned 60 organizations have made that commitment to become executive members. I'd say the PCPCC brings together a lot more than just 60 virtually and also in webinars like this, as well as conferences and other policy and advocacy initiatives. But the 60 organizations that have taken that extra step to become executive members have the opportunity to be active participants at the table. And the table is already set with stakeholders from like-minded organizations, associations, initiatives, all collaborating to determine the strategic direction of the PCPCC. The executive members are also there to join the collective voice of respected thought leaders working to achieve the shared principles of primary care, and you can see those at the pcpcc.org website. And also executive members can help the PCPCC directly and effectively respond to the healthcare environment, forging a path forward to elevate primary care so it can deliver on its promise to patients. And finally, be sure to save the date for the PCPCC annual conference, which is going to be held this fall in Washington, D.C. It's coming up fast, November 4th and 5th. Highlights from the conference you'll see on the screen. Registration is now open at pcpccevents.com. And attendees of today's webinar will get a $100 off discounted registration using a code webinar 2019. So now I'd like to take just a couple of minutes to introduce our expert panelists for today's discussion. First, we have Dr. David Rubin, who is the Director, Multi-Campus Program in Geriatrics Medicine and Gerontology and Chief, Division of Geriatrics at the University of California, Los Angeles, Center for Health Sciences. He is the Archstone Foundation Chair and Professor at the David Geffen School of Medicine at UCLA, and Director of the UCLA Alzheimer's and Dementia Care Program. Dr. Rubin is past President of the American Geriatric Society and former Board Chair, American Board of Internal Medicine. Dr. Rubin continues to provide primary care for frail older persons, including making house calls. We also have with us today Morgan Davin. He is the National Senior Director for Health Systems for the Alzheimer's Association. He joined the Alzheimer's Association in 2017 to lead the development of new ways to engage health systems and healthcare professionals for increased access to timely diagnosis and quality care. Morgan established the Alzheimer's Association's Project ECHO Hub, which provides care-based learning programs to improve person-centered care in primary care and long-term settings. He He has spent most of his 24-year career in public health, leading clinical and community partnerships to increase access, improve quality, and achieve health equity. And finally, certainly not least here, we have Carolyn Question, who is a gerontological nurse practitioner and is the Associate Dean for Clinical and Community Partnerships at the Neil Hodgson Woodruff School of Nursing. She's responsible for the Office of Clinical Placements and the Emory Nursing Professional Development Center, including the Wound, Ostomy, Continence Nursing Education Center. Her nurse-led patient-centered medical home for people living with dementia, the Integrated Memory Care Clinic, represents a one-of-a-kind clinic model that provides integrated memory, palliative, and primary care. So I think you'll agree that we have phenomenal experts today who can share their experiences and perspectives with us on this very important topic. Following the presentations from the three speakers, we will then open the floor for questions from attendees. The way you'll ask questions, typical webinar format, you'll send the questions in. I'll do my best to monitor those questions. I will most likely not interrupt the speakers during the course of their speaking, and I will save them to the end. We'll have about 10 minutes or so for Q&A at the end if all goes as planned. So with that, I would like to turn it over to Dr. David Rubin to kick us off.
Great. Thank you very much, Rob. Rob introduced the speakers, and I'll just give a brief overview of what we plan to cover over the next 50 minutes or so. We're going to talk about the magnitude of the problem. Morgan's going to talk about some new guidelines for diagnosis of dementia. Carolyn will speak about outreach programs to identify persons with dementia. I will give an overview of a population-based approach to caring for persons with dementia. Then we'll have some examples of innovative programs. So I'm going to turn it over to Morgan.
Okay, thank you, Dr. Rubin. So this again is Morgan Davin, and I'll be sharing a little with you now on the significance of the disease. Excuse me, I'm taking this slide back where we need it to start, pardon me. So the prevalence of dementia, Alzheimer's and dementia, is significant, as are the cost and other impacts of the disease. And if you'll just bear with me, I'm working on getting our slides back to where they need to start for this section. And okay, I think we're getting there. So again, my apologies, bear with me for a moment here. So we know that with Alzheimer's, there are more than 5 million Americans who are living with this disease, and it is the most expensive disease in the United States. And as the size and proportion of the US population, that is ages 65 and older, continues to increase, we know that the number of Americans with Alzheimer's and other dementias will also continue to grow. In fact, these numbers are projected to grow to as many as 88 million Americans with this disease by 2050. We also know that with the cost of the disease, as I said, it is really the most expensive disease in our country today. And so the cost of caring for Americans 65 and older who have Alzheimer's and other dementias is currently projected to be more than $250 billion this year, which is more than or close to $13 billion since last year. And then as we look further out in time, we know that the current projections for 2050 is that these costs could rise as high as $1.1 trillion. And pardon me again, trying to advance the slide here. And it looks like I may need some help from moderator on this because it does not look like I'm able to take control of the slide to advance it at this time for some reason.
Okay.
That's okay, Morgan. We'll take control, and you can just let me know when you'd like for us to advance the slide.
I appreciate that. If you would go ahead and go to the next slide, please. Thank you. So as I said, by 2050, these costs could rise to as high as $1.1 trillion for the cost of Alzheimer's and dementia in the United States. And we also know that, and if you can take it another slide or two forward, that would be good. We also know that because of the prevalence and the cost of this disease, and also the nature of this disease, it adds to the difficulty and the cost of managing care for older adults in many ways, not only specific to dementia, but also it means that with these older adults, those who have Alzheimer's and other dementia, it leads to more expensive hospitalizations and increased emergency department visits. So this means that there are really substantial and really very negative impacts on efforts, including in primary care, to help patients manage comorbidities, including very common chronic conditions such as cardiovascular disease and diabetes. And these efforts are further undermined when we factor in that the rates of diagnosis and disclosure for Alzheimer's are really quite low. Less than half of those cases are actually diagnosed today. The good news is that we have significant opportunities in primary care to address this disease, including timely detection.
Morgan?
Yes, go ahead.
If I could just ask you to pause just for a second. I'm getting some feedback from individuals on the line who are not seeing the slides advance. So Yolanda and team, if you all have any suggestions there, that would be appreciated.
It does look like we're about where we should be on the slides on my screen. What I'm seeing is the benefits of early detection.
Good deal. Looks like it's, and I'm getting some feedback from attendees that they can now see the slides advance. Sorry to interrupt. Thanks. Go right ahead, Morgan.
Very good, thank you. So hopefully everyone can see the slide now that addresses benefits of early detection. An important aspect here is the benefit to the caregiver, which I'll say a bit more about that in a moment. But you can see on this slide that with early detection, in addition to an accurate diagnosis, there's opportunity for more medical benefits, opportunities for participation in clinical trials. Many of those opportunities are really best suited or designed for those who are in the relatively earlier stages of the disease. And very importantly, planning for the future, as well as getting emotional and social benefits, getting the emotional and social support that both the person living with the disease and the caregiver need now and will need going forward. And speaking of the caregiver, for the caregiver, resources and support that help them prepare early in the progression of the disease and help them cope with the challenges of caregiving as the disease progresses. These are really important aspects of dementia care. So really thinking about this dyad of the patient and the caregiver. And person-centered care is really best achieved when the person who is living with dementia is able to learn about their condition early enough in the disease process that they can fully participate in decision-making now and in planning for their future. So again, this timely detection and knowing what the right next steps are upon a diagnosis is a really important aspect of person-centered care for older adults who have Alzheimer's or another form of dementia. Will you go to the next slide, please? The next, yeah, so very good, thank you. So you should see a slide about practice guidelines. The Alzheimer's Association is working with a consensus group to develop practice guidelines for the clinical evaluation of Alzheimer's disease and other dementias for primary and specialty care. And these, we are hoping that these will be out and published in the new calendar year. And these really are going to be for both primary care and specialty care clinicians, physicians and nurse practitioners. So this will be really quite relevant and we anticipate very helpful for primary care clinicians and their care teams. And this will also address best practices for partnering with the patient and their loved ones, their care partner or caregiver, so that we can help improve patient autonomy, care, and outcomes. So this is at least a little bit of a preview of what's possible in addition to the burden and prevalence of the disease, what is possible in primary care. And Dr. Rubin and Carolyn Clevenger are going to share a lot more about, more specifically, what is working in some care settings now, including some things that are really quite relevant and also accessible for primary care settings. So with that, I'm going to turn it over to Carolyn Clevenger. Carolyn?
Thanks, Morgan. I'm going to try to take control of these slides and see if that works. Oh, good. So I'm going to talk to you all about one project we have here in the state, across the state of Georgia, specifically to target that issue of identification and early detection. And this is a state-funded initiative, so it's coming from the state's operating budget, to identify individuals in the state so that the state can then program plan for better services and to meet the needs of these folks. So identifying close to 400,000 individuals in the state by phone survey last year who had self-reported perceived cognitive impairment, and said 80% of them said they had not brought that to the attention of a healthcare provider, but that they were open to the discussion. And as mentioned before, one of the challenges with missing that early detection is that you have these preventable additional healthcare and personal costs while you're trying to identify something is off, but we're not quite sure what it is. And sometimes if you don't know, if you haven't named the problem and you have a known symptom arise, it's now an unknown symptom and we're working things up unnecessarily. And the goals of the project are to create these memory assessment clinics around the state, and you can see the dots around the state. They're all attached to academic medical centers, in particular for family medicine residency sites, so that for our primary care practices in the state who are hopefully conducting those annual wellness visits, that's another piece of that project, who are doing a screening tool. If they have a positive screen and they're not comfortable doing that diagnostic evaluation, that they have a local site. So hopefully these memory assessment clinics will be within 90 miles of all of the citizens of the state, where they can have that assessment, have a reliable diagnosis, and then be connected with local services in their area for continued care and programming. And this is through collaboration with a number of organizations around the state. We happen to coordinate it here at Emory, but it's actually not at Emory. The dot that you see over Atlanta is actually at Grady, our safety net hospital. And in wonderful collaboration with our state chapter of the Alzheimer's Association, I'll add. The process sort of looks as follows. So we're hoping initially to improve that assessment, or at least screening during annual wellness visits, that people are then referred to memory assessment clinics and then are backed and with their primary care provider, as well as those community-based services that we're connecting them with our community service educators. And then, of course, because this is a large statewide initiative and program, that the data that's collected to identify how cost-effective this has been and evaluate our own performance in meeting the objective, which is, of course, to improve those outcomes and the quality of life for people, the person affected and their families who are dealing with memory loss or forms of dementia, but also streamlining our services and offering more efficient care. These are the specific locations across the state that we're covering. Again, Atlanta is at Grady, and then the other sites are in relationship to academic sites where there are family medicine residencies. And then just another recap of the workflow in terms of what happens before they come to our visits, when they come to a memory assessment center, what they're receiving, the person and their care partner, that our team is sort of coming together, discussing the results, the diagnosis, and then jointly coming up with an interprofessionally created care plan, which is then discussed and reviewed with the person and their care partner, identifying their goals, and then, of course, attaching them to different levels of care, including primary care, their informal family support, community-based care, and then ongoing follow-up, either with primary care or maybe in conjunction with memory assessment. So I think it's just sort of a helpful example of what you can do with an entire statewide population with a number of collaborators. I think many of us in primary care are sort of thinking, what can I do in my practice? And I'm often reminded that sometimes you can do a much larger initiative in collaboration and leveraging your partnerships across sites. And I'll hand it back over to David now.
Okay. So I'm going to actually shift the focus a bit from detection and screening to actually what you do to manage dementia care. So the way to think about this conceptually is a population-based dementia care model. Now, by population, we don't mean the state of Georgia or the state of California. What we're really thinking about a population here is within a health system. So the people that you're caring for. And this is an example from UCLA that takes a look at the 5,000 people we have identified who have dementia. And if you take a look in the pyramid, it talks about their utilization. And it's just one way of categorizing these people. And it's actually pretty easy because we have data on all of our patients in terms of what healthcare services they utilize. So if you look at the very top of that pyramid, that's the top 1%. And these people are very expensive. On average, 49 bed days a year, 4.7 ED visits a year. They consume over $180,000 a year. And they have a lot of behavioral problems, but the other thing is they're frequently very sick. They have recurrent pneumonia, they have recurrent urinary tract infections, they have multiple chronic conditions. The second tier are the 2 to 5%, and for our 5,000 patients, that represents about 200 patients. And these people also have high utilizations. They cost about $60,000 a year. The third tier is those people who are the 6% of the 20th percentile, and they cost about $20,000 per year. And then the two bottom tiers are people who have the diagnosis of dementia, but they really don't consume a lot of health care. So one of the strategies to think about here is who needs what, because you wouldn't want to give the same health care to the people who are in the bottom tier, who have very little utilization, that you design for the top tier who have a lot of utilization. It just wouldn't be cost effective to do something like that. So we'll go into this in greater detail in a few moments. So the new models of comprehensive care for dementia focus on both the patient and the caregiver. There are a lot of models in the community that focus only on providing caregiver support, but the puck is moving really towards comprehensive care. And these fall into two big categories. One are based in the community. What I mean by this is that they're typically based at senior centers or community centers and run out of there. And there are a couple of examples. One is called the BRI care consultation model. Second one is Mind at Home, which really relies on home visits. BRI care consultation is almost all exclusively telephone. The second big category are health systems based. And this is where the people coordinating and managing the care of dementia are actually paid for by the health system. And typically these will reach out into the community. So the next slide will give you a little bit deeper drill down. The CBOs are typically staffed by social workers, nurses, or MFTs. They provide systematic assessment, care planning, delivery of referral care. They may or may not have in-person visits. Typically they don't. And they've been shown to have reduced caregiver burden, strain, and depression, better guideline-associated care, improved quality of life, reduced behavioral symptoms, reduced nursing home placement. but by and large, these have not had any effect on overall healthcare use or costs. In contrast, the healthcare systems are typically based in healthcare system, and typically they're either nurse practitioner or physician-led staff. They often will have at least face-to-face annual visit. There's coordination within the healthcare system. These providers have access to the electronic health record. Many cases they can do order writing. They may or may not have home visit, and they've been associated with better quality of care, reduced caregiver burden, strain, and depression, reduced nursing home placement, and many have shown lower healthcare costs. So I'm going to turn this back over to Carolyn, and she will give an example of the latter category of a health system-based dementia care program.
Thank you. So Integrated Memory Care Clinic is our model here at Emory Healthcare, and essentially when we say integrated, we mean the integration of primary care and dementia care in one location. And I would say, related to the population-based model that we've just seen, 90% of our people fall in that tier 1 through 3. If you can sort of envision. Oh, see if I can take control. There we go. So one of our patients early on, we've been around 4 years, a little over 4 years at this point. One of our patients early on described us as the Walmart of dementia care, which I'm assuming she meant in the best possible way. But the idea is that it's this one-stop shop, so people can come to this site to get, again, both that geriatric primary care and memory care in one place. So we essentially incorporate actually 3 lenses. So much of what we do comes from our geriatrics background in terms of our own clinical training. That we are more narrow than that, though, focusing specifically on this population of people who have Alzheimer's disease or related dementias for their both the neurological and, in our case, geriatric psychiatry as well. And all of that is done through this lens of palliative care, and so that we also have our palliative care specialists on staff and are doing essentially primary and specialty palliative care for these folks. When we try to describe the work that occurs in this setting, this is the graphic that we used early on. So in a model where we're doing primary care for people living with dementia, first call your attention to that subtitle, which is that it's a nurse-led medical home. And so to David's point, this is a nurse practitioner engaged office visit practice. We would update this language now to describe ourselves as a nurse-led physician-supported practice, which is certainly the case. And we are a patient-centered medical home. When we conceptualized the model, we, from the beginning, from our origins, identified ourselves as fitting really well philosophically with the medical home model, and of course pursued recognition and have had that and maintained it since we've been open and had enough patients to submit metrics. I'll then call your attention to the center of this graphic, because I think this is really key to many of these models and the success, which is the triad approach. So in our case, it's a nurse practitioner as the primary care, but the practitioner in triad with the person who is affected, who should be participating in this care to the degree that they are able, and their care partner, many times who is the family caregiver, who, and I will tell you, is the most effective intervention that I have in terms of my management plan from a medical perspective. And so engaging that caregiver or care partner as part of the team is the most helpful thing. And if there's one thing a primary care provider is hearing from this presentation today, I hope that that is one of the takeaways, that if that's the most effective intervention, you really have to engage them, and you can't leave that intervention out in the waiting room, but they have to be part of the medical care and the visit as much as possible. So to that extent, I'll draw your attention to the 2 lower quadrants, which is that it's really important to us that we provide care with patients and caregivers as opposed to patients, and that you can describe it as patient-directed or patient-centered care, including a written care plan that is provided to them. And that's at the visit level. Now, at a larger level, we are really fortunate to have a patient and family advisory council, which is composed of about 10 individuals at this point who are now all current or former care partners, or I should say, of our current or former patients, who we use as an external advisory council to review and give input on patient flow, services we offer, and all family and patient-facing communication goes essentially through that council for their input. And then to the lower right, the caregiver support, again, is really critical, but I have to do the work to educate, inform, activate that family caregiver or care partner, so that we're also offering through the clinic psychoeducational training, and in our case that is Savvy Caregiver or the Rosalind Carter Institute's Dealing with Dementia courses, so that there's a course. And then also individual or family counseling by our licensed clinical social worker, and then stage-based support groups. Again, I'm trying to make sure that they have the best information and tools at their disposal to do the hard work of being a caregiver. Now, on the top left, I think we do essentially what any geriatric primary care practice would do, in that we're managing those minor acute illnesses that come up, as well as those comorbid conditions, in addition to the dementia-related symptoms. What we were told by family caregivers as we put the model together is that to see someone separately, for example, for diabetes management, that is still done through the lens of the fact that this person has varying and progressively less capacity to manage the regimen that goes along with diabetes care. And so to do those two things separately just was not logical to them, which is why we do those things together, and of course with the base of best evidence available to us. And then that top right, that lens of comprehensive palliative care, so that we're having early discussions and repeated discussions about the goals of care, what's most important to this person. We do the traditional advanced care planning discussions and visits, but even as granular as families and individuals tell us, I want to talk about those standard screening recommendations that are coming to me. When should I be doing them? When should I not be doing them? What are the real risks to me given the fact that I have this other condition at play? So what does it mean high level then to do both dementia and primary care in one setting? These are the 5 things that we would say that we do that people can do in other settings that are not necessarily this unique model, which is to be intentional about assessing the appropriate things. In particular for us, that's those behavioral symptoms, because we know that drives so much of the caregiver burden as well as acute care utilization. And then to recommend appropriate and sometimes aggressive treatment about the right things. You know, occasionally when patients or families hear that you're coming from a palliative care lens, there is this sense that you're always looking to do less. And I would say we're always looking to do the most appropriate. The cornerstone of the patient and family experience being what it is, which has been extremely positive, is the second piece, which is being available. And I say clinicians, but in fact I mean our clinical staff. So having that availability to call us directly, and after hours in particular. So we take after hours call by nurse practitioners, evenings, weekends, and our family advisor just told me this week that she's never used the after hours line, but it is actually her favorite part of the clinic, because she knows she has access to somebody who can talk her through an issue if it comes up when most practices are not available. Connecting people to community-based service providers is also critical for us, because so much of what happens in dementia care is outside of the medical care. And then getting that input from patient and family advisors. And the last piece I would say is to leverage the interprofessional team. And of course, we put our team together to match the needs of this specific population, which has been a luxury, frankly. And when I look at the team, this is sort of how we organize the graphic to share with families. So this umbrella of integrated memory care means both dementia and primary care. And I'm trying to describe to them that they will see in visits our nurse practitioners. After hours or during the day, they may hear with the registered nurse. The social worker is here to provide them contact with community support, but also does a lot of the delivery of education, support, and counseling when appropriate. And that our patient family advisory committee advises us on many of these things. And again, the patient coordinator in our health system, which is, you know, a large academic health system, you make appointments through a central call center, and our clinic uses a direct line, and we go bypass that call center because it's just too challenging for our patients in particular and for their care partners to go through that central station to try to explain to them what it is that they need and how to and sort of how to juggle some of the things that happen even with making appointments. And you might imagine, you know, in a smaller practice or a dedicated practice like ours, and we call to do a patient reminder for a visit the following day. And if you call the patient who may be listed in your medical record system to say you're coming tomorrow and they're like, nope, I'm not coming, I cancel. It's always nice to have the patient care coordinator who knows that person likes to try to cancel their appointments quite a bit. So we know to call the care partner next to say, hi, going to see your mom tomorrow, just so you know she tried to cancel her appointment. And that seems to go much better because we get them in here. So to give very high level some of the outcomes that we've been able to enjoy, it's really important to us to be the best primary care practice as well as the best dementia care practice here for a variety of reasons. And we've been really thrilled to see that we have actually outperformed the goals for the healthcare system this year for management of those chronic conditions like hypertension and diabetes, even in a patient population which most people would describe as complex. And outperforming system goals for things like preventive care. So we're still thinking about immunizations and appropriate screenings. The ones that are not appropriate for our patient population, I sort of ignore those. And in terms of adding value to the health system, I would say for all of us, our true north outcome is the ability to avoid those ambulatory sensitive admissions. We have not been above 2% in over 2 years at this point. I think we're 1.5 last month, and then really seeing a very positive response from the patient and family experience through the standard metrics. And with that, I'll pass it back to David.
Great, thank you. So I'm going to talk briefly about 3 other models, and I think the important thing here is some of the similarities among models and then some of the differences. So Carolyn presented was a primary care model of primary care providers who do integrated both primary care and dementia care. Another system is the Health ABC system, which is at Indiana University. And here they focus on patient and family education, data collection using standardized tools, coordination of care transitions across multiple settings, patient-centered non-pharmacological interventions, modification of the physical and social environment, and engagement of palliative care and hospice. So you'll see these kind of components throughout many of the health care models for dementia care. Oops. And the way they do it actually is a multidisciplinary care team that starts out with the physician, and then there are nurse practitioners and nurses and social workers who are much more supervisory roles. And then the real guts of the operation are community health workers and care coordinator assistants who work with patients and families. The care coordinator assistants are non-licensed, and they are the primary liaison between the care team and the patients and caregivers. They conduct visits, they go into the home. It's a very important component of this model. And the care is also delivered through phone and email. Their model has evolved a lot. Early on, it was much more higher level professionals. And in that earlier versions, they were able to demonstrate fewer emergency department visits, fewer hospitalizations, and shorter lengths of stay. In the new model that I just described above, there have been some cost savings, but not as much as the original model. The next is a brand newly reported delivery system that came out of the University of California, San Francisco. It was just published last month, and it is the care ecosystem, and it is exclusively telephone and internet based. On average, people receive 15.3 calls a year, so about 1.25 calls a month. And once again, they use a team of unlicensed care team navigators, plus backup dementia specialists who are advanced practice nurses, social workers, or pharmacists. And they create also care plan protocols that are focused on the immediate needs of medications, safety, referral and caregiver educations, caregiver well-being, behavioral management, and advanced care planning. They published in a randomized clinical trial that improved person with dementia quality of life. That's an instrument. and then decreased ED utilization, decreased caregiver depression and burden. Now, this is once again the Indiana model and the UCSF model are using lower level personnel to try to attain the goals. The last I'll present is the UCLA Alzheimer's and Dementia Care Program, and that is a clinical program with goals to maximize function and independence and dignity, minimize caregiver strain, and reduce costs. And this is once again based in the healthcare system, reaching out to the communities, but differs a bit from the model that Carolyn presented. The nurse practitioners only manage the dementia component, and the primary care of the patient otherwise is managed by the primary care physicians. And in doing so, the dementia care specialist conducts in-person needs assessments. These are typically 90-minute in-person initial visits, develops and implements individualized care plans. These, once again, are written care plans, monitor response, and once again, providing that kind of access 24/7, 365 days a year. And I just love what Carolyn said, that having that peace of mind that that's available is very important. Here, the caseload for each of our dementia care specialists is about 250 to 300 patients. And just some outcomes here. These scales I'll mention very briefly. The green one is the mini mental state exam. That's a test of cognition. And this program does not improve cognition. It does not change the course of the disease itself. Nor does, if you take a look at the orange line at the top, this higher numbers mean worse functional status, which means that the program does not change the disease. But for the patients, behavioral symptoms are less frequent at 1 year, and patient depression is less frequent at 1 year. As far as the caregivers, all of the scales that we administer to them, this includes distress from patient behavioral symptoms, overall strain, and caregiver depression are all improved at 1 year. And we've done quite a bit of examination of the effect of this program on costs. It reduces hospitalizations by about 12%, which is not quite statistically significant. ED visits by 20%, ICU stays by 21%, total hospital days by about a quarter. And this is accompanied with a 60% increase in hospice use. Overall, the cost to Medicare for this program, fee-for-service Medicare, is about $2,400 less than matched controls. And there's about a 40% reduction in nursing home placement. So getting back to the population-based model, if you take a look at the right side, what are the appropriate interventions? So those people in the top tier and the second, maybe third tier, you're probably looking at a more intensive program. One of the things that Carolyn said is virtually all of her patients are in the top 3 tiers. And indeed, in the Alzheimer's and Dementia Care Program, the vast majority are in the top tiers. For a program that is aimed at less severe persons that provide much more community-based referrals and caregiver support, such as the care ecosystem, you might be aiming more at the tiers 4 and 5 program. So one size probably doesn't fit all. And just an example of how we're taking this population of the 5,000 people who have dementia at UCLA, for that top 1%, we're referring them to what we call extensivists, who have smaller patient panels and follow people inpatient and outpatient. We also have a home visit program that's jointly staffed between a nurse practitioner and a physician. So these are people who are really the frailest to keep them out of the hospital. Many of the people in the top 1% and tiers, top 20% are referred to the UCLA Alzheimer's and Dementia Care Program. Those people who are having recurrent urinary tract infections are referred to urogynecologists. And those people in the top 1%, frequently they're being referred to palliative care. Whereas those people in the top, in the bottom 21 to 100%, those tiers 4 and 5, we have developed an information and referral system that is staffed by a social worker care coordinator who knows all the community-based resources and also functions according to protocols. What we've begun to do is actually program our electronic health record so that based on certain utilization patterns and diagnosis, we can prompt the primary care providers to making these referrals so that we can appropriately triage people based on their utilization and their diagnosis and how sick they are. So at this point, I'd like to just conclude by saying, despite the lack of very effective medicines, and the medicines aren't very valuable at this point, the lives of persons with dementia and their caregivers can be improved with lower healthcare costs. Several models are effective, and choices should be guided by the population served, local resources, and institutional goals. So at this point, we have some time for questions, about 10 minutes, and I'll turn it back to, I guess, Rob to monitor the questions.
Yeah, thanks, David. I appreciate everybody's perspectives. Great job. Very informative. I'm going to kick it off with some questions that came in online during the course of this webinar. There were some pre-submitted ones as well, but I'm going to start with some that might be a bit more timely in light of the presentation. And these are in no particular order, but there was one that came in related, Dr. Rubin, to some of the statistics that you shared. So here's one. As most of the participants in the studies that I think you had shared are older adults, do we really expect that the ED and admissions to drop at a statistically significant rate post-intervention?
They do. Both pre and post data and comparison with control groups show that that the utilization is less, and that may be for many reasons. When we dig down a little deeper, the length of stay is shorter, and that is maybe because the receiving teams, like the Emory program or the ADC program, are ready to get these people out of the hospital already, and they have a lot of social services lined up for them. But also because people choose to avoid intensive care units, and oftentimes they also decide that staying at home is really much more consistent with their overall treatment goals.
Great, thank you. Okay, Carolyn, question came in that was directed at you and caregivers. So bear with me for a second as I find it. Okay, how does your team, Carolyn, engage the family caregiver on a day-to-day basis?
Sure. So one of the things that I think all health systems are now required to do because of the CARE Act, but we started doing as we built our documentation systems in the medical record, is that there's an identification of the care partner. And so we have sort of our dashboard, which puts that information in the forefront for the clinician when you're talking to that person or you're talking to their advocate. So that's sort of in one piece. I hear from family caregivers and care partners that when they access what I'll call usual care, that many times they are told that there are privacy concerns and that they are not able to be part of the visit in the exam room. That's not something that we have ever made part of our model, and so they're sort of almost always, it would be an exception in our case. And we don't require, I know there are models that require that the patient have an advocate or a care partner. We don't. We do allow people to access us independently like any other primary care practice, but we do sort of guide toward engaging someone else in the process, in the process of caring for them. So they're always sort of part of the visit. There's also, of course, I'm interested in information about them in terms of their resources, their network, and what they are. So they're not just sort of the informant to me. Again, they're also my intervention. And so I'm interested to know what resources they bring, what their experience has been, what's important to them, and what's been really difficult or challenging for them. Because as much as I can mitigate that, that's another way that I'm getting at those avoidable hospitalizations, frankly. I say that all of our care partners need some kind of training because this is a pretty intense job and they haven't been trained for it. So whether that means that they engage in a blog, an online support group, a face-to-face support group, a class, a reading, one of those things needs to happen though. And so I'm going to try to, encourage that and make sure that they get connected to the information that they need, that they're willing to access. Many times they become our primary point of contact for not just scheduling appointments, but for managing medications, coordinating all of those community-based services that I'm trying to connect the person to. So they become increasingly more and more of the decision maker as the disease progresses. And so my ability to help them anticipate that and sometimes to dance that fine line between respecting the person who is affected and also stepping in to make decisions when their capacity is too impaired to make the level of decision that we need to make. So people sometimes are like, oh, your clinic, it's for the caregiver. That's really where you're targeted. And it's not. It is a both the person and their caregiver.
Thanks, Carolyn. I was going to follow up with a couple of questions that I think you answered in the course of your description about working with patients and caregivers. I'll just share with you, though, the types of questions that have been coming in with some key words that I think are really important. So one question came in, which I'll highlight the words awkward and disrespectful in this question. So patient and caregiver care is most, how do you navigate talking about the patient while they are in the room? Is there a process strategy around this awkward and oftentimes disrespectful interaction for the patient? So that's one. And then there was another one that is similar in the sense that there's a lack of understanding regarding dementia. There's fear with being diagnosed. So any ideas and tips on how best to communicate? So I think those are related questions. I think you touched on some of it already. You even used the word disrespect in terms of avoiding being disrespectful and being mindful of it. Anything additional to add in light of those additional questions that came in?
Absolutely. I think one of the fun things about doing geriatrics broadly is that you are dealing with a person, and in their support system, in particular with family, these people are not new to each other. They have now a lifetime of patterns of communication, and of course those range. You can sort of say the continuum from functional to dysfunction. That's one way to look at it. But there are certainly families where they have very direct and open conversations about what they're observing, even in the context of someone who is unaware of their symptoms. They're still able to do that, but that's a lifetime dynamic that's been going on for some time. And then, of course, you have the more challenging cases that we all think of as clinicians, where you're trying to balance this exam room where you have a person who is maybe unaware of their symptoms, or they're experiencing, they're concerned about stigma and shame about some of the things this person is describing that they're doing, and they're saying, why are you telling her this, So, of course, our goal is to make sure that the person affected also has a positive experience of care. I'll give you two really practical suggestions for the people listening in primary care right now. So one strategy that has been effective for us is sometimes we always begin our visit talking to the person, and we're engaging with them and asking them about things. I generally will ask permission, or I'll at least let them know I'm going to now talk to this person, your daughter or your spouse, and I might be talking about you. But so when I shift to that the care partner in the room, sometimes we'll use a strategy where we name the person something other than the patient. So we say, oh, that Rose. Rose, she wakes me up really early at night or really early in the morning, and she won't go back to sleep, and she's rummaging through the closet. I can't figure out, she really needs to go to bed, but I can't figure it out. And I mean, there actually many times, more than you would think, that's actually been a very safe strategy. We're talking about this third person, or sometimes the care partner will describe symptoms that they themselves, they will say, I'm having some issues with, urinary accidents. They, of course, are talking about the patient, but we're talking about them in that conversation, and that actually goes pretty well. In one instance, we had a patient who looked at the two of us and said, who is this Rose? She sounds like a nightmare. Now, the other practical strategy is, if that's not going to work, I will use outside visit time, which I should be able to bill as non-face-to-face time with the care partner. And once I have already established a relationship and I know that it's going to be sensitive in the exam room, I call in advance of the visit. It actually only takes me 10 to 12 minutes, and I get all of the symptom history that I need. We can talk about all of those sensitive things that they don't want to say in front of the patient. And then when they come in, I can just focus on the patient because I already got the background from the caregiver talking about those sensitive topics without being disrespectful. So those are just two practical strategies that we've found have been helpful for us.
Great.
And what was the second question?
I think you covered it, Carolyn. It was
okay.
Around engaging with the patient, doing so with the caregiver, the awkwardness associated with it, which I think you covered.
There was a question about the difficulty of the diagnosis, though, and that's a longer conversation. I will just simply say, when we're disclosing diagnosis or we're talking to somebody who has a new diagnosis, I also am talking to them about the plan. And so I think there are some recommendations for how to disclose that diagnosis in the practice guidelines that Morgan mentioned. But then there's also and we'd like to talk about next steps. Let's talk about the plan. We're not sort of just giving you this diagnosis and telling you to go home. And you, of course, can only talk about the plan as much as they're ready to talk about it. But there is a management plan that I have for them. Sometimes that's helpful.
Great. Thank you, Carolyn. Excellent points. I will say that among the many questions that have come in, which we didn't even get to most of them, I did get some really nice comments about how informative today's session was, so thank you. We're just at time, and I want to thank everybody, in particular today's experts, for all of your insights that you shared. Thanks also to all the participants listening into the webinar today, as well as the PCPCC staff for making this happen. You'll find additional resources from our panelists on the slides that are going to be available for download on the PCPCC website, along with this webinar. And remember to check the PCPCC website for registration information regarding upcoming webinars, and be sure to check the site for the upcoming conference that's taking place in early November, so in Washington, D.C. So thanks, everybody. Have a great rest of the day, and thanks again to our experts for your insights today.